Hello, my name is Michael Killip, and I will be presenting on behalf of my team on our study titled The Association of Frailty Status and Outcome of Hip Fracture Patients in a Northwestern Ontario Cohort. I would like to disclose that I am a resident learner in the orthopedic surgery program at Nottingham University. The study has received financial support from Northern Ontario Academic Medicine Association Clinical Innovations Opportunities, which was a grant awarded to Dr. Travis Marion. This presentation falls within the learning objectives of Theme 1, which are clinical and translational health. It describes current research in surgery and primary care. It identifies strengths and limitations of surgery and primary care research, and it assesses and analyzes surgery and primary care research potential impact on clinical practice. Frailty is a clinically recognizable state of increased vulnerability and compromises an individual's capacity and or their ability to cope with acute stressors. To be deemed frail, an individual must possess 3 out of 5 phenotypic criteria, and these include low grip strength, low energy, slowed walking speed, low physical activity, and unintentional weight loss. 15% of individuals over 65 and up to 50% of individuals over 85 are considered frail. Unfortunately, this population is more susceptible to fractures, cognitive decline, hospitalizations, and even death. In Northwestern Ontario, hip fracture incidence and the need for surgical intervention is rising. However, it is still unclear whether frailty is associated with worse outcomes within this specific cohort of patients. The purpose of our study was to examine whether frailty in hip fracture patients in Northwestern Ontario is linked to worse outcomes. This study was approved by the Thunder Bay Regional Health Sciences Research Ethics Board, and informed consent was obtained from all participants. Data were then anonymized and used solely for academic purposes. We prospectively recruited patients presenting with hip fractures at Thunder Bay Regional Health Sciences Center. Frailty was assessed using the modified 5-factor frailty index, which scores based on the presence of 5 specific comorbidities. These include history of congestive heart failure, diabetes mellitus, both insulin or non-insulin dependent, chronic obstructive pulmonary disease or pneumonia, functional dependence at the time of surgery, and hypertension requiring medication. The Modified 5-Factor Frailty Index is an update on the 11-variable Modified Frailty Index after the National Safety Quality Improvement Database no longer mandated the reporting of 6 of their variables. Statistical analyses included chi-square tests for categorical variables, Spearman's rho for correlation, and ANOVA for differences across continuous variables like BMI, age, and number of adverse events. Scores were then grouped into 0, 1, and 2, as well as greater than 3. Data analysis was performed using JASP and GraphicPad Prism. Our analysis revealed a significant association between increasing age and higher frailty scores as measured by the Modified 5-Factor Frailty Index. Patients with higher scores were significantly more likely to experience preoperative adverse events and had higher 12-month mortality rates. This relationship is visually represented by a right shift in the frequency distribution among patients who experienced at least one preoperative adverse event and those who died within 12 months. ANOVA testing further supported these findings, showing that patients with modified 5-factor frailty scores greater than 3 experienced significantly more preoperative adverse events compared to those with scores of 0 or 1. Our findings demonstrate that frailty is significantly associated with worse preoperative outcomes and increased 12-month mortality in hip fracture patients within the Northwestern Ontario cohort. These results align with broader literature, which highlights frailty as a strong predictor of adverse health events in older adults. Notably, higher frailty scores were linked with increased preoperative complications and long-term mortality, underscoring the importance of incorporating frailty assessments into surgical risk stratification. Interestingly, we did not find a significant association between frailty and post-operative complications. This suggests that while frailty may not directly impact immediate surgical outcomes, it certainly plays a crucial role in shaping a patient's health trajectory before surgery and in the long term. This distinction is clinically important as it reinforces the need for early identification of frailty in the emergency or preoperative setting. Interventions such as optimized perioperative care, closer monitoring, or multidisciplinary planning could then be implemented to reduce risk and improve patient outcomes. Our study supports the growing call to include frailty screening as part of standard care for older surgical patients, particularly those presenting with hip fractures. By integrating frailty assessments into routine practice, healthcare providers in regions like Northwestern Ontario can better stratify risk and allocate care appropriately. Further research is warranted to explore targeted interventions for frail patients and determine whether addressing frailty preoperatively can improve long-term outcomes. In conclusion, the Modified 5-Factor Frailty Index is a valuable tool for identifying hip fracture patients at higher risk of preoperative complications and longer-term mortality. Early frailty assessment is key to guiding clinical decision-making and long-term care planning.